all for joining here with us on this BOA webinar on all about meniscus. I quickly introduce all our speakers here. Dr. Manish is here. I think, yes, Dr. Manish will be speaking on anatomy and biomechanics of meniscus. Then Dr. Shivam Sinha from BHU will speak upon meniscectomy versus meniscal repair, when and how. Then this talk will be followed by Dr. Rakesh Chaudhary, faculty at PMCH Patna, by bucket handle tear repair and resection. Then the next three talks will be one by Dr. Romesh Gaur on Dehradun, radial tear repair, video and presentation. Dr. Rajeev Raman, old friend and a very dear friend from Kolkata, will be presenting on root repair and video technique. And lastly, Arvind will be taking, Dr. Arvind from Paras HMRI Patna will be taking on ramp repair, video and pictures. So yeah, and thank you all, Dr. Madhusudan, Dr. Sarraf sir, Dr. Rajeev Raman, and everybody else for joining. Thank you all for joining. So all the panelists, I think Gurudeo, Rajeev Raman sir, Neeraj Srivastava from Varanasi. Neeraj has already been here, I guess. Prabhat Prakash from Motihari, Sarthak from Bhubaneswar has joined. Vivek from Patna will be joining. Sarjil Rashid from Patna will be joining. And Avinash, my colleague at AIIMS Patna, will be joining as well. So welcome you all. And I request Dr. Manish to start sharing his screen. And we all will follow our time, 10 to 12 minutes for our presentation. And we'll see if we can take few questions in between two talks we'll take. Or if there are any questions, we will try and filter it out and we'll pass it on to the speaker. So Manish, Dr. Manish, the stage is all yours. Your presentation is visible. Please go ahead.
Yes. Good evening, everyone. Thank you, BOA, for giving me this opportunity to present a paper on anatomy and biomechanics of the menisci. A complex topic, but an important topic. At the same time, this topic can be a bit boring. See, I've tried to collect the data from various sources and present it here in a way as simple as possible. If you can spare 15 to 20 minutes of time, it might be beneficial to all of us. So let's start. Yes. So basically the menisci, they are discs of fibrocartilage which is interposed between the femoral condyle and the tibial plateau. The medial tibial plateau, as you can see, it is longer in the anteroposterior plane in comparison to the lateral tibial plateau. The central portion of the plateau, they are void and it represents the articular area. And the lateral meniscus plateau is almost circular and it is less concave, whereas the medial one is concave and then the superior surface of the lateral surface is not very concave. The menisci covers around 2/3 of the peripheral 2/3 of the tibia. It deepens the articular surfaces and stabilizes the joint. The upper surfaces of menisci are concave, whereas the undersurfaces are flat. Peripherally, the menisci thickens and it gets attached to the synovium and capsule. Centrally, the border of the menisci, they are thin and it exists as a free edge. The length of the medial meniscus, that is around 3.5 centimeters. And the anterior horn of the medial meniscus gets attached to the tibial plateau just anterior to the attachment of the ACL. And some of the posterior fibers from the anterior horn, it traverses and crosses the joint and gets attached to the lateral meniscus, and this is called the transverse ligament. The transverse ligament. But posteriorly, the medial meniscus is anchored to intercondylar fossa, and that lies between your PCL and the lateral meniscus attachment. And along its periphery, the medial meniscus is attached to the joint capsule and the deep MCL. And as far as the mobility is concerned, the medial meniscus is less mobile, whereas lateral meniscus is more mobile. Almost 10 millimeters of excursion is done by the lateral meniscus from flexion to extension. Here you can see the excursion of the lateral meniscus. The average excursion is around 11 millimeters. And the medial meniscus average excursion is around 5 millimeters. So as I already told you, the lateral meniscus is circular, covering larger portion of the articular surface. And as for the width of the anterior and posterior part, it is almost similar. the lateral meniscus. The posterior and the anterior part, their widths are similar. And the anterior horn of the lateral meniscus gets attached near the intercondylar spine, posterior to the attachment of the ACL. Here is the anterior horn of the lateral meniscus. Whereas the posterior horn of lateral meniscus gets attached to the posterior intercondylar spine, which is anterior to the attachment to the medial meniscus. The lateral meniscus is not attached to the LCL, but it has got loose attachment, or is loosely attached to the synovium along the much of its length. There are two ligaments, the anterior and posterior meniscofemoral ligaments, which are known as Humphrey and the Risberg ligament, which lies or attaches from the posterior horn of lateral meniscus. It extends back, and anterior and posterior to the PCL, it gets attached on the medial femoral condyle. Here you can see one of the meniscofemoral ligament, Risberg. The tendon of popliteus muscle, on its way to the lateral condyle, it crosses the joint through a hole in the lateral meniscus, and that hole is called the hiatus popliteus or the popliteal hiatus. This area along the popliteal hiatus, that is a avascular area. Here you can see some of the structures on the lateral, posterolateral, the stabilizers of the posterolateral area. Now, the vascular anatomy of the meniscus. It is relatively avascular, it having a peripheral limited blood supply, and the supply is by the superior and the inferior genicular arteries. It forms a premeniscal capillary plexus, and from there, radiating arteries or the radial branches extends inside the menisci, the radial branches. And as far as the penetration is concerned, on the medial meniscus side, around 10 to 30% of the periphery of the medial meniscus is penetrated by these radial branches, whereas on the lateral meniscus it is around 10 to 25%. And one point to be noted that the vascularity of the outer thirds, that is maintained almost throughout the life, and very little changes with the age. The microscopic anatomy, if it is considered, the menisci are composed of water around 65 to 75%, collagen 20 to 25%, and the non-collagenous substances, which comprises of proteoglycans like matrix glycoproteins and elastin, that comprises 5%. As far as the collagenous network is concerned, it is having a very complex orientation. The layers of the menisci, if they are considered, there are 3 layers: superficial layer, lamellar layer, and the deep central layer. The superior or the superficial layer, that is in contact with the tibial and the femoral articular surfaces. The fibers of collagen, they are very randomly arranged, and they are mixed with the lubricating layer of the proteoglycans, which allows them a low frictional surface. Beneath this superficial layer lies the lamellar layer. It has got an external area and an internal area. The external area consists of radially oriented collagen fibers, which intersects with the internal fibers at various angles, creating a mesh. The vertical fibers in lamellar layer projects into the central main layer, securing them together, and also helps in the transmission of force between the two. In the central layer, the radially oriented fibers are known as the tie fibers. They can also integrate with the lamellar layer through perpendicular branches. The tie fibers holds the circularly oriented circumferential collagen fibers, which are found basically in the periphery of the central main layer. Now the tie fibers increases from anterior to the posterior region in its numbers, which increases its stiffness. The circumferential fibers are larger bundles and comprises mainly of the type 1 collagen, and majority of them are located in the internal and external circumference of the menisci. The radial tie fibers, the purpose of it is it resists the splitting of the circumferential fibers, and it may contribute to the compressive properties of the menisci. The circumferential fibers undergoes a great tensile or hoop stresses when they are loaded axially. Now coming to the biomechanical properties of the menisci. The first and foremost property is its viscoelasticity. The menisci are considered viscoelastic. What does it mean? It means that throughout an applied load, they exhibit two types of properties. One is viscous and the other is elastic. Now the transition between them is time dependent in nature. It begins with the elastic phase and then it shifts to the viscous phase while it is being loaded. So the elastic quality of the menisci or the solid phase of the menisci, that is governed by your collagenous proteoglycan structure. Whereas the viscous or the fluid phase is due to the permeability and the water content of the menisci. Now what happens? Fluid is slowly extruded out. This accommodates the compressive load without excess deformation, and that lets the beginning of the viscous phase. And this is a very important characteristic of the tissue permeability. What happens, the important characteristic is that the fluid through the interconnected pores between the solid matrix of the menisci and the synovial space, there has to be a clear permeability of the fluid from the solid matrix to the synovial space. Now, when it is compressed, the menisci is being compressed, under compression, the meniscal permeability determines the rate at which the fluid will be extruded out. This meniscal permeability is much lower in comparison to the articular cartilage, thus giving it the ability to maintain its shape during axial loads. And what happens during the gait phase, the stance and swing phase, especially in the heel strike or the moment to the stance phase, what happens? The menisci maintains their load-bearing capacity and it resists the fluid loss and maintains its shape. If the menisci could not maintain their shape, that would be essentially a non-functional menisci. The viscoelastic property of the menisci plays a role in the compressive resisting forces. Now, when the constant load is applied to the knee joint, the initial compression on the menisci, that is resisted by the elastic property of the collagen bundle and matrix. Now, following this initial load, there is a diminished rate of compression when the fluid phase begins to take over. Now, as the fluid is extruded out, the compressive load is resisted and this is called the creep. At this phase, the menisci relaxes and the load needed to maintain that given held compression decreases. And this is known as the stress relaxation phase. So the creep and stress relaxation phase is very important for the menisci. Now, as the compression force is applied, the circumferential tension develops, and this leads to the hoop stresses. The menisci gets extruded peripherally due to the wedge shape, causing the radially oriented tangential force. Now, this peripheral extrusion is prevented by the anterior and posterior meniscal attachment. That is the anterior and the posterior root, the attachment, the horns. The hoop stresses allows distribution of stress over a larger area of the articular surface, and this is an important function of the menisci, where it is considered that it distributes the load that is due to the hoop stresses because it is getting distributed, the force is getting distributed. Now the radial fiber, if there is a radial tear, this can disrupt the circumferential fiber and that can lead to the loss of the hoop stresses, resulting into a dysfunctional meniscus. Now it is also said the posterior horn of the medial meniscus has got a higher aggregate modulus than the rest of the menisci. And maybe this is because this region undergoes highest compressive stress and is most commonly injured site. Here you can see the axial load and which is getting transferred to the circumferential fibers through these radial tangential forces. Now the response to tension. What is the tension? Tension means it is the behavior of any tissue to the stretching force. And when the stretching force is applied, that the effect is elongation. So how much resistance to elongation is there for the tissue? So that is called tension. So when the menisci undergoes tensile forces, initially there is very little force needed to elongate the menisci because the collagen fibers are relaxed. Now after this initial relation, after this there is a linear relationship between the elongation and the load applied, and after that there is a dip in the elongation where the fibers fails and it begins to tear. Now, what is the maximum load which the menisci can bear? That is known as the ultimate tensile load. The tensile properties can change depending on the location of the menisci. In the superficial layer, there is no differences in the tensile strength, but in the deeper layers, in the central layer, that is the deepest layer, the circumferential fibers have got a greater tensile modulus than the tie fibers. Now, if the middle meniscus is considered, the highest tensile modulus lies in both the anterior as well as the posterior region. And studies have shown that the lateral meniscus, the reports are showing that the posterior part of the meniscus is having a higher tensile modulus, but other studies are showing that there is no difference between the tensile modulus both in the anterior as well as posterior region. In general, it is said that the menisci have got a tensile modulus of around 150 megapascals. ACL has got it around 200 to 300 megapascals. Polyethylene has got it 1000 megapascals. And the radial fibers has got a mean of 11 megapascals. The last one is the response to the shear. Now, what is shear? Shear stiffness, it is the measure of the material's resistance to changing shape. The menisci have got low shear stiffness relative to cartilage, which is having almost more than 100 times more shear resistance. So the low shear stiffness allows the menisci to maintain an optimal congruency between the tibia and femur throughout the range of motion, thus ensuring even load distribution. Additionally, the tie fibers, it segregates the circumferential fibers. This also contributes to the low shear modulus of the menisci. Now, the shear modulus is found to be lowest in the posterior portion of the medial meniscus. Now comes the clinical biomechanics. So what is the menisci functioning as? It is basically a spacer, like a spacer between the femoral and the tibial plateau, femoral condyle and the tibial plateau. If the menisci are removed, the amount of narrowing that can be there, that would be around 1 to 2 millimeters. Joint becomes very close to each other. And if the lateral meniscus is taken out, the consequence is much bad in comparison to the excision of the middle meniscus. Now, during extension, 0 degree of extension, about 50% of the compressive load is transmitted through the menisci in 0 degree of extension, which increases to around 85% when it is at 90 degree of flexion. And the menisci increases the contact area to around 2.5 times.
Dr. Manish, sorry, I request you to quickly wind up the presentation in next 1 or 2 minutes, if possible. Okay. How long is it left?
Last.
Just 3
to 4 slides.
Okay. Quickly wind up, please.
Yeah. I already told you this is a very boring topic. The lateral meniscus, about the range of movement, if you can see, the range of movement is around 10 millimeters in the AP direction. And this mobility is explained by the close attachment of the anterior and posterior arms. And there's a lack of attachment of the capsular ligament on the posterolateral aspect, where the medial meniscus is more firmly attached to the tibial condyle by the deep MCL, while the lateral meniscus is relatively mobile. And this can be one factor which makes medial meniscus a more important stabilizer. As the knee flexes, the menisci moves posteriorly. And during extension, the menisci are pulled forwards by the meniscopatellar fibers, which are stressed by the anterior movement of the patella, and this draws the transverse ligament forwards. While the posterior horn of the lateral meniscus is also pulled anteriorly by the tension developed in the meniscofemoral ligament as the PCL becomes taut. The medial meniscus shares around 60% of the weight of the medial compartment. Lateral meniscus shares 70%. The larger contact areas provide the menisci, which reduces the average contact stress between the joint surfaces. Even if we remove around 15 to 34% of menisci, this can increase the contact stress by around more than 350%. The medial contact area reduces by 20% after removing 50% of the posterior segment of middle meniscus, and which can lower down to 54% after total meniscectomy. The medial contact stress increases from 24% after 50% meniscectomy and 134% after total meniscectomy. After total lateral meniscectomy, the result can be 45 to 50% reduction in the total contact area and 235 to 335% increase in the peak local contact stress. The peak contact stress is directly proportional to the amount of the meniscus removed. Now, there is a condition called PCL meniscectomy. What is that? What is that? That happens during PCL ruptures. There is an increase in the posterior tibial translation, which leads to the loss of the weight-bearing portion of the menisci being out of the low transmission area. So that is not able to bear the weight, and that is considered as PCL meniscectomy. So lastly, finally, it comes to what is the basic function of the menisci. So it acts as shock absorption, load transmission, secondary restraint, role-in proprioception, and joint lubrication. Once the menisci were considered to be vestigial tissue. So what can be the take-home message? The take-home message is the tissue which was once considered to be vestigial has been proven to be very important. Very difficult to replicate or duplicate the function of menisci provided by the nature. So hence, think twice before removing even a small piece of meniscus until unless it is absolutely essential. And if you can't make the situation better, do not do further harm. Primum non nocere. Thank you.
Excellent, Dr. Manish. Thank you very much. So if there are any question, we'll take a question before the next slide by Shivam, Dr. Shivam Sinha. He will load up his screen and load up his slides. And I'd welcome also Dr. Bhushan. Bhushan Sabnis is a very good friend. He's my co-moderator in this session here. Welcome, Bhushan. And Bhushan works in sports med in Mumbai, and he's a very well-known figure throughout the India for his sports injury work, arthroscopy work. He does a lot of arthroscopy, meniscus, ACLs, and ACL, PCL, and corrective osteotomies as well. So he's a very well-known figure, and we look forward actually whenever he's in a webinar. I can make it a point to see it. So any questions, Bhushan, or anything you want to emphasize? What are your indications when you take think about removing any meniscus? I think, yeah.
So what Dr. Manish did was really brilliant. It was a really good talk, and it really brushed up a lot of issues about biomechanics, the basic biomechanics, as well as the effect of meniscus in saving the joint as such. There are two things which are important. Of course, we'll come to that in the next talk about meniscal excision versus repair. We need to be careful about which menisci can be saved and which can be excised. I think the next talk will be much more in detail about that. But we all know whatever we can save is fantastic. But be careful about jumping the bandwagons and trying different repairs. So I've seen people trying to repair spaghetti menisci with very, very bad results. So just be careful.
Case to case, we have to decide that. Next talk.
So it's always better to individualize the treatment based on the patient's status, the requirement of the actual tear. But excellent talk. Thanks.
Okay, so I think more light will be thrown on this by Dr. Shivam. Dr. Shivam, the screen is all yours. Please go ahead.
Yeah. I just want to. Okay. Am I audible?
Yes, sir. Slide is also visible, and you are quite audible. Please go ahead.
Can I proceed?
Yes,
proceed, please.
So I at the outset, I want to thank the Bihar Arthroscopic Society and Bihar Orthopaedic Association for organizing this webinar on all about meniscus, and the topic which I have been given to talk on is about meniscectomy versus repair, when and how. I'm thankful to Dr. Manish for making my job much easier by giving a very good overview about the anatomy and functions. And we'll be walking through about the pattern of injury, repair techniques, clinical results, decision-making, and current recommendations. So anatomy has been well spoken of. We know that lateral meniscus is more articular and has more coverage, and both of the meniscus are peripherally vascular. Patterns, I'm not talking about the patterns or the mode of injury on which the treatment has to be individualized, whether it is traumatic, degenerative. The most common in traumatic one is about ACL injury with vertical longitudinal tear patterns, which usually heals well. And degenerative, mostly in the older people, which are common horizontal cleavage types, which may heal poorly. Ramp lesions are new entities being discovered, and they are difficult to visualize, and root tears are something which warrants attention. Figure shows about the classification of the root tears, which will be talked later. The repair concerns whenever we are taking for the repair, that certain points are always being researched and taken care, that what is the location of the tear in terms of a red or a red white zone, what is the configuration, what is the anatomy of the repair, whether it is a horizontal tear, whether it is a complex tear, whether it is a parallel beak, all depend upon the type of fibers which have been disrupted and the extent which is involved. What is the complexity of the repair, how old the repair is, and other thing which is an important factor is the patient's age and compliance. Another thing which we usually see about the knee stability and knee alignment. So these are the concerns when one is contemplating for a repair. The typical indication which has been taught to us and what we usually do is to go for an acute tear of meniscus, which is traumatic, mostly vertical longitudinal, having a length somewhere between 1 to 4 centimeters, and peripheral zone, red zone are more important in a young patient with a stable aligned knee. So the techniques we usually opt, which are, I'm talking of arthroscopic techniques like outside in, inside out, and all inside. In the outside end, that once the tear is identified through transelimination, a suture is passed from outside, retrieved, passed across the meniscus, and is tied over the capsular structures so that meniscus is opposed and reduced, and this is suitable for repair of anterior and middle third of the meniscus. The inside out is more of gold standard. We usually practice much and use specialized cannula like zone specific cannula. And the suture is passed from inside, and depending upon which meniscus we are dealing with, whether it is a medial and lateral, according to the anatomy, the neurovascular anatomy, incision is made and the suture is again tied so that the meniscus tear is reduced. It is mostly apt for the tears of posterior and middle third of menisci. All inside is the new technique, but mostly reserved for the posterior horn tear. And the 4th generation repair devices, they allow for placement of sutures in the meniscus, and then self-adjusting and sliding knots are applied so that meniscus is reduced. Medial meniscus, posterior horn, they are more important as told in the previous lecture because it bears most of the commercial strength. So what clinical results till now we have obtained based on the technique, whatever technique you are using, the technique is about 70 to 95% successful. When you do for a second look scopy, you find that the success rate has lowered either because the pattern of the choice of the tear which was chosen was not correct or the tear has not healed. It has reduced to 45 to 70%. Overall, 5-year survivorship for an isolated meniscal repair ranges somewhere between 60 to 70%. Factors which affect maybe more like complex tear, rim width, and many other factors which are affecting the outcomes. Ligament laxity is not addressed, then the repair is likely to fail and success rate further drops down. And the success rate in conjunction with ACL tear when ACL reconstruction is contemplated, and at the same time meniscal tear result can be as good as 90%. What is dilemma which is based on the evidence? We know that there is a higher functional outcome in repair, but as per literature, Baxter et al., there is a higher reoperation rate as well. There is a limited success in certain tear patterns like central tears. There is a longer rehabilitation and sportsmen might miss their present season. But in the study by Steen et al., the long-term result to the return to sport is as high as 96% as long as 8 years follow. What if you do menisectomy? It affects the hoop stresses, it reduces them, but the result depends upon how much you are resecting it. As told, if you resect more, the tibiofemoral contact pressure increases more. And that is the reason an early onset degenerative joint disease is seen, but it may not be symptomatic as late as by 16 years. They can keep on working, but X-rays might not look good or MRI might not look good. Technically less demanding and a shorter rehab is there. So what are the tools what surgeons usually have in deciding what will the present knowledge, what standard indications are, and the intro of findings. And we have also some MRI-based speculations or predictions And this is one of the tools which recently have been published in 2019 by alumni from our institute, our KSSTA, that they are taking, and which is all known as Ortho-1 prompt score from Ortho-1 hospital. They are taking criteria like age, chronicity, and X-ray features of the osteoarthritis, along with the zone of tear and pattern, and they are assigning the scores. As the score rises, chances of meniscectomy is increasing, and as the score is less than 6, meniscal repair is contemplated and it is predicted. With this scoring, they could find from their study that almost for medial meniscus, which is less mobile and more likely to re-tear, their sensitivity for repair is about 91%. That means if they have planned a repair on the MRI finding, similar repair they can do post intraoperatively, and specificity is 93%. However, for lateral meniscus, the predictability is reduced. There are 69% sensitivity and 79% sensitivity is for meniscectomy. So what are the contraindications? Very long tear, we are going to excise it. Central radial tear, less than even 25% involvement should not be touched. Central avascular zone tears, complex, radial, flap, cleavage, all type of maybe better discarded with meniscectomy can be done. Degenerative meniscal tear, articular cartilage in the axillary compartment is in contradiction. Most important thing is an irreducible tear. Tear which you are trying to reduce and is not reducing, and you have fixed it in an unreduced position, this is going to land up in a fuss later. Unstable knee and older non-compliant patients are contraindications to it. And this is what the editorial of KSSTA by experts opinion has talked in 2020 in their second consensus regarding traumatic meniscal tear. They have generally agreed upon preserving the meniscus whenever possible. And they have said that meniscal pathologies like ramp lesions, root tears have high incidences than expected, and once visualized, they should be repaired regardless of the age. The risk benefit for using biologics like PRP and growth factor is yet to be researched, and it's an open arena. Degenerative tears, horizontal, complex, extending in the avascular zone, are becoming an extended indication of repair, because as the tear will less be addressed, more degeneration will continue. So tear has to be addressed by something amenable for repair. And there is a concept of combined resection and repair. And this is the part which need to be conservative in resection and more towards repair. So the revised indications are like patient factors. Patient has to be active. The age is just a number. The patient can be active, but has to be compliant, has to have a BMI less than 30 and no significant comorbidities there. Tear characteristics more or less remain the same: red zone, red white zone, simple tear patterns, acute tear associated with ACL reconstruction. But the most important thing, that tear, whatever you are going to repair, it should be without excess tension. There is a lower threshold for complete radial tear, root tear, ramp lesions, which we will see in the upcoming videos by our next speakers. So the current recommendations as the pendulum swings, and this is from the latest systematic review by Monacaria in 2019, published in EJOST, that there is a limited data comparing between these two techniques because of absence of RCTs. Partial meniscectomy can be done wherever the repair is contraindicated and the tear is symptomatic. There is no consensus for ideal technique. You can use either of the techniques on any of the implants, but there is no difference in the outcome as early as 5 years. The learning curve is rising, so meniscal repairs are rising because awareness for meniscal preservation is increasing. Focus is to save as much as possible. The most reliable technique is by placing vertical divergent sutures almost every 4 millimeters along the length of the tear. So length of the tear is no more an contraindication. Indication has been extended to any age which is having root tear, ramp tear, and the patient has to be active and compliant. And the longer rehabilitation period in repair, as well as a chance of reoperation, has to be explained to the patient preoperatively.
Excellent, Shivam. Very nice talk, Shivam. Thank you. Thanks a lot. So there are no live questions, but
can we have some discussion over here? Because I think this is the most important talk, so that when to repair is the most important thing right now, because most of the failures which we are seeing in our practice of the repairs are because of the wrong indications. What I have felt, irreparable tears. So one important question which I would like to ask with Dr. Shivam, what is the time duration under which the patient will come and you will repair?
So you say as acute the tear is, and what are the concomitant pathologies you are doing to deal with. If there is an ACL reconstruction, acute ACL, you're reconstructing the ACL, you try and attempt to repair, see the reduction of your tear. As the tear is reducible, you repair at the same time.
So any time
and if you see that tool, what I was talking of, the Ortho One Prompt tool, they have taken the duration as late as up to within 1 year.
1 year.
And if you see the revised indications, they say it is better if you intervene early, maybe 3 months. The more important part in dealing with meniscal tear is isolated meniscal repair. They still have a higher reoperation rate. You might have land up doing a second look arthroscopy and do a menisectomy. But when you are dealing it with an ACL tear, and then you are repairing the menisci, the chances of healing is much better.
So now my second question, which I was about to come. So when we are repairing the ACL, we are getting stem cells. That is the reason it heals better. Correct? So
no, may not be. You are getting
there
ACL. You are reducing the translation as well. And the translation is also dependent on the menisci translation, which is anterior and posterior.
But in isolated tear, in which there is no ACL tear, in that there is no translation. But the reason why it is healing better with an ACL reconstruction is because we are getting stem cells. That's why many papers are there that we should put PRP also. Many people are putting primary PRP also with meniscal repairs to improve the outcome.
Correct.
So, and one more thing, what about the age, any age limit or alignment issue also you are looking if you're planning to repair a meniscus?
Yeah, definitely. The age is what the recent meeting has said in ESCA, that the patient has to have two things. He has to be lean and thin, he has to be active, and he has to be compliant to your post-op protocols. Right. If you start loading your repair, or your repair is not properly reduced, that is one of the technical failures. In ACL, we know that if the tunnel placement is not properly, it is going to land up somewhere into a failure. Similarly, for menisci, when they are not reduced and you have attempted that this implant might reduce it and let me do it, and that is just to hold it. That is just to create a havoc later, and that land up in a reoperation. And about the alignment issues, yes, definitely, the sir has explained very nicely regarding the hoop stresses and the tensions and the translation. This all depends how femur and tibia are correlating each other during the flexion and extension. And similar, at that time, your menisci and your repair are also adjusting along the alignment and various surfaces of both the articular cartilage on both the sides. If they are not conforming it, and alignment is not proper, then your repair is kind of at a jeopardy. Other experts may also opine. Bhushan sir?
Yeah, so yeah, I agree with most of the discussion that we have. That actually brings us perfectly what I wanted to ask. So someone, let's say a 22-year-old athlete comes to you with an isolated meniscal tear, let's say lateral meniscus. We are going to repair it for sure. What are the chances you are going to put something else apart from the meniscus repair? So the reason I'm asking you is you just mentioned PRP. Yeah. What about stem cells? What about fibrin clot? What about
fibrin clot also? I was actually coming to this question only because many things are being added on to just enhance the, especially when you are doing the red-white zone or the white-white zone.
Yeah. So what I was trying to ask is, of all the panelists and speakers, what is the opinion about adding something more to an isolated meniscal tear repair?
So Rajeev,
we are going ahead now with radial tear repair as well. So what do we need to do to allow that meniscus to heal better?
Enhancement, yes.
Yeah. Rajeev, go ahead. Yeah.
Yeah, I think biological augmentation is must. And if, for me, isolated meniscus tear, I do some microfracture in the intercondylar notch so that there is bleeding from the intercondylar notch. Again, needle technique is very predictive technique and a very effective technique where you can put your needle from outside in multiple puncture, and that usually proliferates the vascular channel for meniscal healing. And third most important is PRP or clot, fibrin clot, when we put fibrin clot. But I think that is very technically demanding. For beginners, I think intercondylar microfracture and needling is the best technique they can do.
Even cost effective, I would say. Even cost effective.
Cost effective, and it's not very technically demanding also.
Reproducible very easily.
Okay.
Acha, one more about the alignment. Bhushan, what you have to speak about alignment, like degenerative tears and root tears. Many people say that you should repair and then do an STO. Many people are just doing STO, it will heal by its own.
Yeah, you have really taken my trump card out of the pack immediately. I was going to leave it in the end. Okay.
Okay. So just the indication, because
Rajeev, is there any role of synovium for regeneration of menisci after repair?
Sudeep, just one at a time. We are getting confused.
Okay.
Yeah, no, I think all these things will come up.
It will come up.
Yeah,
Sure.
it will definitely come up. So I think let's move
on STO. We can have a special session with Dr. Bhushan. He has a very nice talk on STO. Arvind, we can invite Dr. Bhushan for one session on STO.
Maybe next we can plan.
Yes.
Sure.
So can we go back to Dr. Rakesh Chaudhary? Can you start sharing your screen and take us through your talk on bucket handle, tears, meniscectomy and repair?
Thank you very much. Hope I'm audible to you all.
Yes, sir. Yeah, it's
so,
visible to
thank you, Sudeep. Hopefully, many of the things which will be talking about on bucket handle meniscal tear and repair would be repetitive with Shivam, because it is also a part of a meniscal injury, and the indication, most of the indications and other things remains the same. This is mostly for the repair, just because there was some mix-up of the topic of, I just had to talk on meniscal injury. That's why I have added a small video of resection also. So basically this slides will be on the meniscal repair. Is nothing new. On the first meniscal repair was done by Ikuchi in Tokyo in 1979. It was nothing new. The largest study of meniscal repair was by Scott and Jelly, 178 repairs in 167%, and almost he gave a result of 80% of them healed. The best result, as we all know, already told, are obtained when it is associated with ACL reconstruction, when the rim width was less and the repair was done early, within 8 weeks of the injury. So always good to do in the red zone, not to go beyond the 50% of the part. So best repair to be done, and we have to see that it is in the red zone. Importance is, why should we do it? We should do it because it restores the function, maintains the load transmissibility, minimizes contract stresses, and it contributes to the stability, and also helps in chondroprotection. But then should every tear be repaired? If it is so much a good thing to do? No. Appropriate and informed decision is required, and almost 20% is only repairable, not all of them. So literature, the success rate, there is an inverse correlation between the success rate and rim width, the tear length. The patient is, the more the age, the less the success rate, the mean stability, and the BMI. The heavier the patient, less is the success rate. But still, the success rate of various authors have been over 75%, almost 80%, most of them. One has to consider the repairability, the geometry and the technique which we have in hand, the healing potential, the exact place and the time of how old the injury is, there is any associated surgery which we need to do and have to consider the recovery time with it. And the patient preferred outcome and concern, how much is he ready to commit to your repair protocol is important. So the ideal tear to repair, sorry, it is going to be repetitive a bit, patient less than 40 years, traumatic meniscal tear, recent tear associated with cruciate collateral ligament, longitudinal tear within 3 to 5 millimeter from the meniscocapsular junction, and a stable knee. One should avoid repairing in chronic complex tears, degenerative tears, unstable knee without, if we have not done reconstruction, and associated gate flow osteochondral defects is already there. This is a study which says, takes into consideration various location, age, size of the tear, tissue quality, and other things, and gives a specific point. And repair on this, a repair is indicated if the score is less than 4. So very precise and actual where we should go for a repair or where we should wait. But there has been a recent surge in the repair. That is true. Everybody knows that, and we are all doing it. Why? Because early diagnosis due to better imaging technique is not available to all of us. Early treatment is sought by the patient for ACL reconstruction, and many of the meniscal repair are done while we are doing the ACL reconstruction. Better instrumentation and more fixation options are now being available. Various technique, as already discussed by Dr. Shivam, I won't go into inside, outside in technique for the anterior third, inside out technique for the middle third. Ideally, all inside technique for the posterior third, it is ideal, but you can mix and match as you comfort. I won't go into this inside out and outside end technique because already well explained by the previous speaker. So let's go into what we do, a very simple case of a bucket handle tear. We do a diagnostic arthroscopy and we see a tear. We see a tear which is almost at the capsulomeniscal junction, a fresh tear because the fibrillation are still there. We look at it and we take certain points, we shave, and now certain points are being there to increase the vascularity of that place. We take out all the debris from that point. When we do a rasp, it's again something like which your trephinization, you can do it by needle by here. It is all done to increase the vascularity at that point. Important, the meniscus should be reducible before we go for it. We reduce it and measure the distance of the meniscal edge from the capsule. And then through a guide, we take the meniscal repair system. It has a built-in anchor with a fiber wire inside it, with a sliding along its side, as already explained by Dr. Shivam. And we place the anchor goes beyond the capsule. We measure it from behold, so it should, the needle should not go very far distance. It is all marked. We have to go till that distance only. Once we put the two anchor, and then it has got us not there, and we pull on it. As we pull the meniscus, the medial part goes towards the peripheral part. And it is a very stable kind of a fixation. When we do for a second, similar thing. And normally, if it is a bucket handle tear, minimum 3 of them are needed for a stable. Very costly for a person like me working in a government hospital setup. Difficult for me to get this off the shelf. Very costly. Markings are there. You have to be very careful. You don't just shoot through and coming out the posterior. So you can see as we tighten, it goes there. So repair being done. The success rates for all the techniques, most of them are approximately 70%. Second look shows a bit lower. Ligament laxity decreases the success rate to almost 30%. 90% success rate if done with conjunction with ACL reconstruction. This is for all repair technique, is not only for the what we need to do for enhancing healing. Remember, we can do trephinization, synovial abrasion, rasping of the tear edges, fibrin cord, PRP, just was there in the discussion. Nothing new. We all know about it. Many of the time we are able to do it, many of the time we are not. Important, the rehabilitation part, because it's taken longer than an excision thing. Daily icing and elevation, weight bearing as tolerated with crutches, hinge rehab, brace fixed with full extension for 4 weeks, gait assessment and rehabilitation, no resistor knee extension, and high impact for twisting activity for no high impact twisting activity for 4 months. The take-home messages for here would be the visualization and portal placement with a spinal needle is very important. You should locate your places where you are going to put a needle beforehand. You should not struggle with it. Thorough site preparation and debridement and rasping. Assess geometry of the tear, provisional reduction. Reduce it first. It should be stay reduced. Then you go ahead and do the repair. Accessory incision, proper retractor if needed should be done. Select a repair device and method that optimizes the tear pattern and individualize the rehab patient. Just last, because I have been told bucket handle tear, I will give you a very small video about resection also. How to do bucket handle tear resection. You do a diagnostic arthroscopy. You go inside and see the bucket handle tear. So before doing the resection, it should be reduced, becomes easier to cut the meniscus once it is reduced. Cut the posterior on attachment first, but just don't completely take it off, shear it off. Just leave a couple of fibers so that once you should be able to pull it off even when attached. If need, just change your scopes, vision port and the working port as much as you want, whenever you want. Cut it. Once you have taken, there would be a few small segment attached from the base, which you can easily shave it off. And thus it is. You do a relook, and if there's no fragment, it is done. Thank you very much.
It was nice, sir.
Thank you.
So which device you use for repair?
Fast fix from Smith & Fleet.
Okay, so it was all different.
I don't exactly remember, but most of the time I use fast fix from the Smith & Fleet.
Okay. So it was not the single device which we put all the three. It was different devices for all the three anchors.
Yeah.
Okay.
I think the first one was sequent from Convid, which has 5.
That's what I was, because he had put two stitches with the same device. Convid is coming up to 5 stitches you can put.
Yes. Yeah, yeah. 5 and 7.
Yes,
most of the time I'm using the Smith and Nephew one.
Right. So thank you very much, sir. I'll request Dr. Romesh Gaur to load up his presentation. And since there are no questions on online questions, so quick questions to all of you till Romesh loads up his presentation is that when considering time since injury, does it also depend upon the age? And does it also depend upon the zone of injury? So time, zone, and age, how different speaker, panelists, and members present here would take their case-to-case basis, decide upon repairing or excising the meniscus, depending upon time since injury, age of the patient, and zone of the injury. So do you have any guideline in your mind before you go ahead? Arvind, can you take this on?
So when I started doing meniscus repair almost 7 years back, I usually keep rule of 4 in my mind. The rule is 4. First is the age should be less than 40 years. Second, it should be less than 4 weeks of duration. Third, lesion should be in the 4 millimeter from the periphery, so that it should be in the red zone.
Okay.
The 4 one is the stitches distance. If you are putting the vertical stitches, that is taken as the strong stitches, particularly for the bucket handle type of tear, then it should be 4 millimeter apart. Then it should be 4 weeks of non-bed bearing, and till 4 weeks only 90 degrees of movement should be done, not more than that. And patient will return to the heavy activity or other thing after 4 months. So this is the basic standard thing.
No, I wanted a short and sweet answer which you have given. Very nice. Rule of 4. Very crisp answer. Neeraj, your take on this?
I would agree with almost all the points with Arvind. Even I am a little, not very aggressive on repair, because we have to.
I need a quick answer on.
Okay.
When you're considering
it has to be red zone.
Okay.
Red white only if it's a professional athlete or very high demand patient.
Okay.
If I'm repairing even ligaments, then I would be more keen to go for meniscus repair.
Okay.
And I keep knee for extension for 4 weeks. This is the only one point I would differ with Arvind. Okay. I keep extension for 4 weeks. I allow arm only after 4 weeks.
I will include 2 more people before we go on to the next talk. Rajeev, you first, and then if Bhushan could give us his insight after Rajeev. Quickly, what is his consideration when you go for a repair or you excise? So Rajeev, quickly you.
It should be a protective rehab, I think. We should not be as aggressive.
When you consider repairing, so time since injury?
Yeah, definitely, it's the age of the patient, quality of the tissue, and time of tear. For me, I think after 3 months, usually it's not a right time. And the most important clinical finding is when you put your scope inside, if you see the medial border is rounded and its meniscus is irreducible, don't repair those meniscus, because I think you will burn out your finger.
Yeah, that is what a synovialized tissue.
Synovialized meniscus. We call it synovialized meniscus.
Bhushan, quickly, can you give your insight?
I think under the age of 20, everything can be repaired, because any bucket handle under the age of 20 is disaster if you excise. So try and repair everything under the age of 20. I agree with Rajeev. If you have synovialized meniscus, the signs normally are yellowing of the meniscal tissue and adhesions between the displaced portion and the ACL or the PCL. They are bad signs. And I think over 3 months, I won't try and venture into repair of the bucket. So if the knee is locked for more than 3 months, I think it's better to exercise.
Better.
Okay, so we have a great insight from a few of the panelists, and it actually makes life easier for the listeners and the young practitioners when they are deciding till a time they make up their own mind. So okay, all yours, Romesh. Please go ahead and present your.
Visible and I'm audible.
Yeah, it's visible. Yeah, you're audible and it's quite visible to us. Go ahead, please.
So at the outset, I would like to thank Bihar Arthroscopic Society and my old friend Arvind for giving me this opportunity. Meniscus Repair, as we all know, though it has been done for quite some time, but it has caught up quite recently when all these devices came up and when we started recognizing that the results are much better if we repair them timely. Out of all the tears, probably the bucket handle tears we've seen for quite a long time, the radial tears were probably the thing which we all were afraid of. Why? Because if we leave it, the results are disastrous. Repairing them was never very easy. Why? Because in the excellent presentation, the first presentation that we had, the circumferential hoop stresses that actually prevent the meniscus from collapsing, from extruding. Once a radial tear happens, those hoop stresses, they create havoc inside the knee, and the meniscus, literally, if you don't repair it, or in case you cannot repair it, you remove it, the meniscus is probably going to create other changes also, cartilage changes. It can be a very small tear to begin with, and it progresses gradually if it's not taken care of. And finally, the final outcome might be a parrot beak tear or a complex tear. Repair of meniscus radial tears specifically, we all started with the normal horizontal sutures as we do with bucket handles, as we have seen previously. Then paper came which said the cross stitches, if we take it in this X pattern, they are much more, they are much stronger as compared to the parallel stitches. And finally, something like a combined thing came up, which is kind of a ripstop design, so that your stitches, they don't come out even if the patient bears load on them. So these are many studies. My presentation is basically a video presentation, and some of the videos are not mine. I have borrowed it from Smith & Nephew website for the purpose of clarity, because these are really good videos and they show exactly how to approach these tears. So starting with identification of the tear, here we are going with the horizontal sutures, which has been done from time immemorial. So what you do is, we have taken these, we have already taken, we have already taken these stitches. So the device that we can use to take these stitches is, there's a specific device from Smith & Nephew, which is called a Novo Stitch, which is something like a Express-U or the Scorpion that we use for cuff repairs. So you go inside, you bite, the needle comes up, the thread comes out, you take 2 stitches on both the sides, then you pass your, if you want to use the fiber wire, you can use a fiber wire, or you can use a normal, if you have an Athibond, if you are comfortable with it, the patient, any kind of thread that you want to use, and you can take a horizontal stitch with that. I have exactly how we take the stitches, I have that in the video. So this is the device, comes up, and the sutures come up. Then you take the second suture, before these devices, it was not very easy to do these things. You could have done, as we have already seen, outside in repair, inside out repair, but radial tears are most of the times in the middle and body, so they're not very easy to approach from outside. So all inside with these Novo Stitch and other devices, it has actually become quite convenient to repair these. So this is the second horizontal stitch taken. There is an animation on the left side where you see how these stitches come up finally, and this will recreate the circumferential tension forces. The hoop stresses are restored, and there won't be any further enlargement of the tear, and it won't progress to a bird beak tear or a large complex tear. So this is what we were talking about. Initially, it was a radial tear, and it progressed posteriorly, and then along the capsular margin in the red zone, it came off like a beak. That's why it's called a parrot beak tear. These type of tears, how they are different, because you have to convert them. First thing that you have to do is, you have to stitch the horizontal surface into the capsular margin, and then finally you make it into a radial tear, and then reduce the radial tear as you did earlier. The second thing that can be done is, you reduce the radial tear first, in the same way as we already demonstrated with the use of Novo Stitch, or if you have your shoulder devices with you, you can use them also. And then the complete thing can be fixed to the capsule, as we do with the bucket handle tears. So parrot beak tears, though, as we discussed, what meniscus should be repaired. If they are repairable, then only we should attempt these, because if it's an old tear with synovialized tissue, I don't think there's any point doing these things. So initially the parrot beak, the horizontal portion was repaired to the capsule, and then in the same way that we did the earlier repair, the beak is then being sutured to the horn part, to the part which is there. So the second stitch goes in the main body from the beak, then with your and then you take your knots and the meniscus reduces. So the purpose here is to recreate the proper anatomy to the best of whatever you can. Sometimes the repair in these, especially these complex tears, it might not be anatomical, but if you can restore that tissue, that shock absorbing mechanism, and if you can, the hoop stresses can be, it can be the after the repair, if the meniscus can withstand all the load that that occurs on the when we put tensile load on it, then your job is done. Then you probably prevent arthritic changes in the future. So this is the final stitch being taken. I'll just forward it a little bit. So this is another parrot beak tear. So you check whether the how long is the tear, so that you can in your you know what exactly you have to do. You can think about the kind of repair, the type of repair that you want to do in this patient. Then you freshen up the edges. And once the edges are freshened up, then you go forward with your repair. So this is the novo stitch that I was talking about. The suture is taken and the knot is being put. Once the knot is secured, the meniscus falls back into its normal anatomical position. The second stitch is, this is the all inside implant. This is whatever you want to use, fast break, sequent, there's so many available now, or Depumitex implant is also good. So another suture can be taken by that. And finally, with the novo stitch again, you reduce the whole thing to the capsular margin. So in these kind of complex tears especially, it's very difficult to maintain the normal anatomy. So even though there's slight overlapping there, but probably this is still better than removing the whole menisci if it's a young patient. And maybe the nature takes its course and some changes take place, and though the final thing that is being done is to make it a little inferior so that it doesn't impinge on the cartilage. So you try your best in these complex tears, you try your best to restore the anatomy, but sometimes if you're not able to, then maybe you can stay with a little less anatomical repair, but where you're sure that the hoop stresses are maintained and it's not, the tear is definitely not going to progress even if the patient puts weight on it. So this is the final repair, though not anatomic, but probably the patient, if you would have removed the menisci, the patient would have been in more complications as compared to these kind of repairs. So this is not what we exactly want, but this is something which we have to agree with finally, because of the kind of tear that was there. So radial tears, as we all know, they are difficult tears to repair with the kind of devices that we now have. It's not that difficult as it used to be. should be repaired because the hoop stresses, you have to maintain them. You have to recreate the hoop stresses again. Otherwise, it's going to damage it's going to lead to arthritic changes later on. And once you repair, the post-repair protocol is same as we had with handle tears, 4 weeks of rehabilitation and the beautiful rule of 4 that Arvind just now told. I think this is all I have with the videos. Thanks a lot for your patient hearing.
Thank you, Romesh, for a wonderful video presentation. So, Samshul, I don't think there is any question coming up on the forum. If I'm not wrong, I'm also checking it.
I want to put a question.
Yeah, so go ahead.
Romesh, this is Dr. Shivam here. So when I was preparing for the indications for the repair, there is a big dilemma about the contraindications in repairing the radial tear. Now, the relative contraindication which I came across from an older paper which was extending a radial tear extending in the periphery. And in the latest recommendations, they are saying that the central radial tear you need not to repair. So how do you decide whether it is central radial tear or the radial tear which is extending peripherally? When are you, or every radial tear you are going to repair? What is your take?
I think it's very closely related to the previous question also. So what is that one indication which guides you into repairing the meniscus? So I think for me, if the patient has come to me with any kind of tear, I think unless it's a synovialized tear and unless I find it irreparable, or if the body is such that I don't feel the repair would work, if I find a good healthy meniscus there, even if it's extending to periphery, even if it's central, I'm definitely going to repair it, and I've never regretted that. None of my patients has had any difficulty, even if I did those. So for me, if it's repairable tear with a good quality meniscus, not synovialized and amenable to repair, I go forward and repair it.
Shivam boss, the contraindication or relative contraindication for such type of tear that you have asked, that tear is extending to the periphery, because the failure rate is very high initially. But nowadays there is a lot of implant and technique has also changed. The one recent technique is that for the radial tear, particularly that extending to the periphery, you just repair like you repairing the root of the meniscus. You make the hole in the tibia, make a tunnel there, and pull that both the fragment in through that tunnel, so that your meniscus is not movable now. And then you put this circumferential stitch or this horizontal stitches, and then again the cross stitches also. So initial contraindication because of lot of failure. With this technique, the success rate is taken as higher side. So until unless, as Dr. Ramesh has said, it's not synovialized, not degenerative. At the same time, the biology of the knee, any repair part should be considered along with all the things that we discussed about the biology of the knee, whether this knee is having healing potential or not. Many a time knee is arthritic. Then such type of knee is the non-biologic for the healing. At the same time, the biomechanics. So biology and biomechanics should also be considered when you are dealing with the difficult meniscus for repair. Easy meniscus can be repaired with nowadays very good technique and very good implant, but such type of difficult meniscus repairing should be, these two factors also should be taken in.
Radial tears, if you don't properly align them, they keep on tearing from the center towards the periphery. And it puts you in soup because each time you are not ready with the armamentarium to repair that.
What's important is that a radial tear which goes all the way to the periphery is interrupting the peripheral circumferential fibers. So there is also a role for selective resection and repair in these radial tears. So is a golden middle path for all of us here. So if you feel that the free border of the meniscus is not vascular, not repairable, you can just repair the peripheral part in the red zone or even red white zone and resect the central part into a smooth circular shape rather than having a pointed crevice kind of arrangement. What Arvind was mentioning was the Laprat technique. You can always rely on Laprat to come up with nice complex ways of repairing all the structures in the knee. So there's a single or double tunnel technique available for repairing repairing a radial tear as well. Slightly more complex than usual. But the downside of doing that is the meniscal mobility is restricted. So we don't know the long-term feasibility of preventing mobility of the meniscus versus giving the biomechanical advantage. That's something we need to look at. So
especially in the medial meniscus.
Yeah, so I don't know just logically it does not sound that feasible to me yet, Arvind. But yes, I've seen the good results that they have mentioned. But I think the peripheral part needs to be repaired with whichever way you can. And in this scenario, you can do penetration, you can do outside and inside out, whatever technique you want, and get a good repair.
So I'd like all the panelists and speakers to throw some light upon when you are dealing with lateral meniscus and when you're dealing with medial meniscus, depending upon zones, how your technique differs. There are so many things in the market. So starting from you, Romesh, so does it really differ when you're dealing with medial meniscus and lateral meniscus, anterior third and posterior third? So can you quickly take on in two terms?
Technically, no, but the portals definitely you have to switch your portals accordingly. So if you are going for a lateral meniscus, you know which gives you the best approach with the with whatever thing you are using, 360 or sequent or whatever. And if it's an anterior horn tear, usually to reduce the cost, I go for an outside end technique. I don't go for the and it's very difficult to use the all inside technique there. For the body and posterior, I don't think it makes a difference technique wise, but the portals definitely you need to be wise enough to know which portal gives you the best attachment, the best repair.
Sure, excellent. Neeraj, your take on this quickly.
Actually, I always try my best to repair lateral meniscus. I struggle more because I want to save the lateral meniscus more than middle meniscus.
Okay. Rajeev, your take on
this. As Romesh has said.
Okay. Rajeev.
Radial tear, I think any tear close to root, I use most of the time I try to repair it, but central part and anterior parts, for me, it's balancing.
Okay. Arvind?
Most of the time I try to repair until unless biology is fine. And usually I put circumferential stitches. That is the strongest stitch. As we all know, that recently this stitch Novo has been introduced. So I can show this things that I usually do if your permission is there. That circumferential stitch that
when you're showing your video next, because you are the next speaker. So you start.
Dr. Rajeev is the next. So usually I rely more on the stitches.
Okay.
So that it should not only oppose the tissue, it should also give a strength to your suture, repairing suture, so that your meniscus stay there if your range of motion and other part is going on. So usually I try to repair all these meniscus until unless it's biology.
And Avinash, okay, you raise your hand. Avinash, go ahead.
Regarding medial meniscus repair and the lateral meniscus repair, you should have a very low threshold for medial meniscus repair doing pie crusting of MCL. Just doing, if you have a low threshold for pie crusting, you always get a better vision for the medial meniscus. It will be more amenable for repair for beginners. So don't hesitate in doing pie crusting for a medial meniscus repair.
What was really impressive about all the videos we have seen till now is that none of the surgeons have damaged the articular cartilage. Whenever you are doing a meniscal repair, you always leave a signature of the surgeon on the articular cartilage. It stays there for life. So all the videos are keenly looking whether there was any articular cartilage. I wish to point it out, but I've been defeated very well. So I'm quite glad. So pie crusting or no pie crusting, you need a good assistant. You need to make sure your joint is open and don't open the mouth of your instrument till the time you have reached the periphery of the meniscus. If you're using anything like a Novo Stitch or a Scorpion or a first pass, so you need to make sure that your instrument is not damaging the cartilage. The whole purpose of repairing the meniscus is to save the cartilage. If you damage the cartilage in the surgery itself, your whole purpose is defeated anyway.
Okay. So, nice word of wisdom.
I feel it is sometimes very important to do pie crusting, at least in my practice. sometimes it is very difficult to visualize.
Yeah.
Unless you have very good, like Bhushan is having a very good assistant. I think even I have seen him. He can open up any joint without pie casting. I think they have never done pie casting. I remember.
Showed your presentation, and Sarthak, your take. You were the last one to answer my question, and
well,
presentation will come up.
Well, I generally try to repair all the meniscus whichever I can, whether it's a posterior or mid-third body.
Okay.
And as you know, goes from outer in technique. But for me, going ahead with the repair, I generally take a proper, consultation with the patient. I need to know exactly what the patient mind is, which is very much important for me. I can go ahead and do a repair, but if the patient is not willing to go for a delayed rehab and, the weight bearing, because sometimes you get certain people who are really can create nightmare post stiffness and all, they can come with the stiffness. I prefer to keep that balancing option quite open for with me.
Sure.
As I would go again with Dr. Arvind, who said that mobilization to be start and to focus on, to get within 4 weeks some mobilization. Because yes, even when I started my meniscus repair initially, I used to keep it for 3 to 4 weeks, and I have seen patient come the delayed ROM in compared to the patient whom have started in 2 weeks with toe touch weight bearing. They come with a good range of movement later on.
Okay, fair enough. Okay, fair points, Sarthak. So all yours, Rajeev. Go ahead and show us your meniscal root avulsion video technique.
Thank you, Team BOA, for invitation. I think all the tier we have discussed may get in isolated manner, but meniscus root tear or avulsion most of the time is associated with either a ACL, PCL, or collateral injury, because it's a severe injury to the knee which causes a root avulsion or a root tear. So just I will be discussing two types of root repair technique: the medial meniscus root repair technique and the lateral meniscus root repair technique, through a small video demonstration. So this was a 25-year-old athlete, has a rotating injury of his knee, and you can see when you put your scope inside, there is a type 2 avulsion of the root of the lateral meniscus. You can see whole of the lateral meniscus has just avulsed from the root here. And such type of tear is usually common when you have a excessive loading force and a rotational force acting over the knee. So once you identify such type of tear, the second important part is see for the condyle loss also. Most of these tear are having associated condyle loss. If you put your scope inside, you can see there is around 1 centimeter square condyle loss. So there was a dilemma whether to go for something for this condyle loss or just to repair this meniscus so that it can cover this condyle area. And if you search literature, up to 1 centimeter of condyle loss in the tibial side, if it is it's covered by meniscus, most of the time it heals well, because this repair we keep them for protected bearing for 6 to 12 weeks. So by that time you will have some hyaline catalyst formation there. So we planned for meniscus root repair, and nowadays we do it through all inside technique. We have very good instrument, suture passing device, by which you can just repair this meniscus. And here you can see the first and most important step is preparation of your tunnel. Most of this root avulsion, if you drill it in fresh, you will see a raw cartilage area, raw area there, so you don't have to prepare that area. So with the 4 millimeter drill bit, you make a drill over the posterior, over the anatomical location of the root, and pass your suture loop through this 4 millimeter hole. You can see here through this pin, I am passing my suture loop. So once your suture loop is passed, the second important step is park it in the anterolateral, in the anteromedial portal, one of your anteromedial portal. Now, once you have parked this loop, the second and most important part is taking bite through the root of the meniscus. And this is the first, So what is important? So once you have, So now, once you have parked it in the one of your anteromedial portal, take a bite through the root. Try to take bite through the mid substance of posterior part so that you have a good robust tissue inside. And always, as Bhushan told, try to avoid making your signature over the articular cartilage. So whenever you are taking a bite, try to put your first pass mini device or suture passing device towards the lateral gutter so that you are not damaging the cartilage. And this is a first pass mini self-retracting device, and you can see here with this orthopod I am taking this bite. And once you have taken bite through the root, then with your either a loop technique or with a knot passing device, you can take 2 or 3. You can see this is the knot passing device. You can make your 4 and 5 high pitches. And then the next step is passing of this suture through the tibial tunnel. And you can see here, once the yellow loop which we have part in anterolateral part, by you load this suture over the yellow, you can see here the whole of the meniscus is getting sitting well over, and you can see the whole of the articular loss, cartilage loss that was there over the lateral tibial condyle has been covered by the meniscus. And this is, I think, the all inside repair is a very good technique by which you can repair this lateral or medial meniscus root avulsion. And now you can fix it anteriorly over the anteromedial aspect of the tibia, over the post or over the disc. And you can see, once I am pulling it, the whole of the meniscus is getting attached over the anatomical area, and that anatomical area should have enough raw surface so that there is a good fibrous tissue formation between the meniscus root and the crater. The second video technique is, this was an old meniscus root avulsion, you can see here, and here the most important part is preparation of your crater. So when you see a neglected, a fresh injury, most of the time you have a raw area there, you don't need to prepare crater. But when you are dealing with the old avulsion, you have to fix, because up to 6 weeks or 8 weeks or 12 weeks, whenever you see the meniscus, posterior horn of the meniscus is floating, you have to fix it. And this part is most important, preparation of your crater. Why? Because whole of your meniscus will sit inside this crater, and that is important, that you should have a good helipad-like area where the whole of the meniscus will sit and you will have good fibrous healing. Because if you put this meniscus over the cartilage, there will be no healing of the root tissue. So always important, the most important part is create a good crater area. You can see I have removed almost 1 centimeter square of articular cartilage over the root area. And now by the same technique with the ACL jig, you make your tunnel over the, this is the medial meniscus root avulsion. So I am making my tunnel. You can see here with the ACL jig, you passed your 4 millimeter your bit pin over that, drill it with the 4 millimeter guide wire. Just I will make it fast. You can see here now I have passed my bit pin. Now I am drilling, and thus your curate acts like a protector. So by this curate, you are protecting any damage to the root tissue. And once you make this 4 millimeter lower, and again you passed your suture loop through this tunnel and park it in the anteromedial portal. So you can see now I have passed my yellow thread and I'm parking it in the anteromedial portal. Now the next step is taking bite through the root tissue, and here also you can use this suture passing device. You can see here there was some bone also attached with the root. There was some fibrous attachment of this bony tissue with the PCL fibers also. And when you are taking bite, take it away from the cartilage, you can see. And once you take a bite, you can see here it's a self-retrieving device. So what I do normally, I use a 2-0 orthocord, or sometimes if you are not having orthocord, you can use 2-number ethibond also to repair this root. So you can see here now I have passed my orthocord, and you can see it's a self-retrieving device. Now take it through the anteromedial portal, and once you take it to the anteromedial portal, you have a loop there. You can just have a suture, and you can, here you can see. Now this is the loop technique. Over that you can put 2 or 3 half stitches to secure your loop. So you take a bite through whole of the meniscus root, and just it's like a circumferential banding, and now with the knot pusher put 2 or 3 half stitches over that. Now you load this purple wire over your passing loop here, yellow wire, and once you load it and pull it anteriorly, you can see here. So the whole of the meniscus is sitting over the crater area. And this is very important step, because you want to sit the meniscus over the raw area. And that is the reason we are focusing more on creating this crater for good meniscal root healing. And now once your thread is anteriorly, you can push, you can fix it with the post, over a disc, or over a endo button. Thank you. I think these are 2 small videos I have shared.
Excellent, Rajeev. Thank you. So 2 quick questions. If you are doing an ACL reconstruction along with your root tear, what will be your sequence of making tunnels and tightening and passing the sutures? So that's first. And how do you avoid pulling too much of tissue in your tunnel that you have made? Am I clear with my question?
Yes, yes.
Okay. So go ahead and answer.
So the first thing is that when you are doing with the ACL reconstruction, always try to make your meniscal tunnel first, pass your suture loop, go for and you can pass it over the anterior vesicular tibia. Just to park it over the and ask your assistant, or you can hold it with the artery forceps. Now make your tibial tunnel for ACL and femoral tunnel for ACL. Go for your ACL reconstruction. After your ACL has been reconstructed, you can suture it over the post, over the anteromedial aspect of the tibia. Second thing is that rewriting whether both the tunnel will collide or not. See, you are acting on a different area, so try to make your ACL tunnel close to the tibial tuberosity and the meniscus root tunnel over the 1 centimeter medial to that when you are dealing with the medial meniscus. For lateral meniscus, you can have two tunnel, one over the medial, one medial to the tibial tuberosity, one lateral to the tibial tuberosity. That you can do. Regarding over tensioning, what you have asked, Sudeep, yes, it's definitely it's a question. Whenever you are getting type 2 repair, where the whole of the root, there's a complete tear of the root, here there's every chance of over tensioning. But believe me, whenever you tie it over the post, over the anteromedial aspect of the tibia, don't pull it so hard. Just pull it, see whole of the meniscus is sitting over the crater. At that time, tie it, and I think that is the best way of preventing over tensioning over the meniscus root repair.
Okay, perfect. Right.
Here
Yes.
just I make one point about the repair of root. So regarding, you have asked about the over tensioning. Other things should always kept in mind whenever you are repairing the root. First, you check with grasper whether your root is coming to the anatomical position what you have made for your tunnel. If it is not reaching, and if you are pulling with the thread or your fiber tape, the chances of tear is very high.
Yes.
And chances of failure is high. So if it is not coming there, then you should do some release at the menisco-capsular junction, so that it's easily fall to its anatomical place. That is very important when repairing the root, particularly the chronic root. Thank you.
And your take on this?
I just want to add something more.
Yeah, please, Dr. Bhushan.
Yeah, so you can once again rely on Laprat to come up with newer techniques. So there's a good technique he described where there's a second tunnel made to centralize an extruded meniscus, and that is indeed a good idea. So you take up a stitch in the posterior medial corner in the medial meniscus, generally not required for lateral meniscus, and you pull the meniscus in through another tunnel, and a second tunnel to hold the root in. So that way you are saving your root in terms of repair. Once again, the same question of mobility of the meniscus arises. But if we consider that the root tear is similar to a total meniscectomy in terms of biomechanics, you can accept some kind of meniscal stiffness, but achieve healing of the meniscus by this technique. So that's something we should all look at more seriously in extruded menisci, whether this technique will help in getting better. And one more thing, Rajeev, that was brilliant videos as usual from you. I moved away from using sutures and moved on to using tapes. So what I found is that a suture tape or fiber tape or ultra tape, whichever company is immaterial, but tape gives a better surface area and the cinch knot doesn't slip through or cut through the meniscus. So that's the only difference from what you showed. But the technique you shown was exactly how I would do as well. Thank you.
Excellent. Sarthak, you raised your hand. You wanted to ask anything? Sarthak, you have raised your hand. Do you want to say? You are on mute, Sarthak.
Unmute yourself.
Unmute yourself, please. Yeah. Still muted, Sarthak. Okay.
Yeah, like I have a question. Sometimes while doing the root repair, I do, when I try to, after getting the reduction, after the like tightening, I do like sometimes get the meniscus as a dog button. It has happened to me slight, maybe my tunnel, because it was a tight knee. I think I did it slightly more anterior and, not exactly the footprint. So do you think I should go and once I get it intra-op, should I go and look for another tunnel, or I can just forget about it? Just asking my curiosity.
Rajeev.
I think dog ear is common when you are dealing with neglected ear, but Arvind also told in such situation, most of the time when you are repairing it, so when you are pulling it also, just see whether that is there or not. It is over tensioning the meniscus. Then you can go for some release, and that is recommended. If you release, I think you can get away with, rather than putting a second tunnel in this root repair, because most of the time you have to go with ACL reconstruction also. So chances of tunnel collision is more if you have made a third tunnel. So better to go with same tunnel and plan for some release.
Yeah, what basically I use this
slide in the meanwhile. Sorry, Sarthak. Arvind, you load your slides in the meanwhile. Okay, Sarthak, go ahead. Yeah.
Yeah, so what I do, like I use the flip cutter, which we use for all inside technique. So I pass the flip cutter and then open it and try to curate instead of this, what do you say that, this curate. Instead of the curate, I use this flip cutter only to remove the cartilage margin. And then that is why I feel like, already there's a tunnel, as you said, Dr. Rajeev, to do one more tunnel, I feel sometimes quite hesitation to kick or a tunnel.
Yeah.
And how do you maintain the PCL tunnel and the root tear tunnel? How do you take care of that?
Normally, both are quite different. See, root tunnels are at a higher level. It's just below the posterior slope, and PCL tunnel are usually 15 to 20 millimeter below the tibial joint line. So you usually most of the time it will not collide. You are quite low for PCL tunnel.
And also we can, if we change the jig angle, I think it won't. I have never come.
Most of the time it doesn't collide if you change the angle by 10 degrees.
Like what I say, yes, correct. 55 for ACL or 55 to 60, and then 65 I keep for my root repairs.
And it doesn't matter where you come out from the tibia. You can do a medial meniscus root tear and attach it to the button on the lateral side. Doesn't make any difference. It's the entry point of the meniscus root or in the joint which is more important. Where it comes out doesn't make any difference. Just make sure.
Rajeev sir, one question.
Yes,
about degenerative root tears, which we were discussing in the beginning.
The last question before Arvind goes on for his presentation.
So degenerative tear, I think if you most of the people who have burned their finger by root repair, there's a degenerative tear because you don't get very good results in those cases. So degenerative tear, try to balance it. If it is coming inside your joint by pulling your probe sometime, you can try, but I think for degenerative tear, root repair is not a good option for me. Bhushan, any comment on this degenerative root repair?
I think HTO first, and then you think of a root
always.
Still have some
good point by Bhushan. Yes. Yeah.
Do we need repair with the STO or only STO would do?
So if it's a degenerative tear which is more than a few weeks old, I don't repair the root. I just do HTO. And quite a few times, as has been proven by various papers also, if you go back in 6 months' time, that tear has already healed because your alignment is changed. So I don't think you should repair a degenerate chronic root tear. If a root tear is within 6 weeks of its injury, it's worth repairing along with HTO. Otherwise, it's just going to fail again.
Mostly those are not traumatic actually. So
So
just leave it. Okay.
Healing is also not good.
So just extension of this question, which is more practical also. I am facing almost at once in a month. So middle-aged patient, 45 year to 50 year, visited to the clinic with knee pain. And as usual, knee pain of 6 month duration, X-ray says it's grade 2 or maybe grade 3 type of problem that OA changes. And usually we ask for MRI also, and sometimes patient comes with the MRI that doctor see it's the meniscus tear and somebody recommended to you go to him. So this 3 to 4 months of pain, medial side pain with grade 2 OA changes, with MRI says it's the tear. Most of the time I face it's horizontal tear, and sometimes this root tear. It's not the complete root tear, it's the partial one. So Bhushan sir, how you differentiate this pain is because of whether it's the meniscal problem or whether it's because of the degenerative joint disease? Because until its pain is not because of degenerative joint disease, this is not going to help with STO. So how you differentiate this? This is very practical one. I faces almost one case in a month.
In grade 2, you can't do STO also. You have to wait unless alignment is bad.
So my approach to this is, so what I consider is a root tear is a part of the progression of arthritis as a disease process. If you think of it in this way, it clarifies a lot of issues. So as your arthritis is progressing, a phase comes when your meniscus is pushed out and the root gives up, and that's why you get a root tear. Now, patients usually present with sudden onset of severe posterior medial pain with a complete root tear. You do get patients who have partial root tear or who are in the natural history of the disease who are going to get a complete root tear. I think if they are in varus, if there are signs of overloading on the medial side, if there is cartilage damage on the medial side, I would still consider them for a HTO if they are consistent with their history of loading pain, night pain, and typical activity associated pain. On the other hand, if I'm in doubt, I would try and use one of the unloaded braces to try and get them offloaded on that side and see if they get better or not. I think it's virtually impossible to differentiate a degenerate joint pain and pain which is coming from partial root tear, in my opinion.
Yeah, usually I do the same offloaded brace for 2 to 3 months and look whether it's getting relief or not. Thank you.
Yeah.
So should I start?
Yes, Arvind,
Yes,
please
yes,
go
sir.
ahead. Yeah.
So my topic is meniscal ramp lesion, which is very common nowadays because of this finding, orthoscopists finding this lesion very commonly, particularly with the ACL injury. So ramp lesion, originally it was described that it's the meniscocapsular junction horizontal tear, longitudinal tear in the posterior horn of the medial meniscus. But nowadays discussion is that it's not so strong a structure, that meniscocapsular junction is not so strong a structure. So this structure is not so very strong. So the consideration of the meniscotibial ligament, through which the posterior horn of medial meniscus attaches to the tibia, which is the strongest one, also taken into this ramp lesion. This is the part. So mechanism is well described very long time ago by Houston. When the knee is in flexion in around 90 degree, it is the contraction of the semimembranosus which pulls the capsule from the meniscus, and that leads to development of this type of lesion, that is the ramp lesion. So usually this ramp lesion is associated with ACL injury. Either it may be acute one or it may be chronic one. When the knee is in valgus, there is anterior subluxation of the tibia that leads to the tear of the ACL. And as ACL torn, the tibia moves further anteriorly, and this leads to the contraction of the semimembranosus, which attaches posteriorly on the medial side, and extension of this attachment also goes to the capsule. So further anterior translation of the tibia with the tear of ACL and anterolateral ligament, this semimembranosus contracts, and this leads to the developments of this ramp lesion. So about the ramp lesion exploration. So this lesion is also called as the hidden lesion or missed lesion, very well described by the Sonri Cotet in American Journal of Sports Medicine, and he says your scope should be in posteromedial gutter first, then at the border of posteromedial portal, you pass your needle and do the probing of your capsule as well as the meniscus. Like here, we can see the first you pass your scope in the posteromedial gutter, and then from the posteromedial portal side, you pass the needle and do the probing of this capsule as well as the meniscus and look for is there any separation or not. Now, similarly, practically also, this is the femur PCL. You enter into the posteromedial gutter with your scope. Then you pass the needle, and then you may probe here, or also if you confirm that your this ramp lesion is very clear with your MRI finding, then you can make a portal and do the probing of this part. And with the increasing knowledge of all these anatomy, the classification has been given for it. This is the normal attachment of the capsule with the meniscus, and this is the meniscus, and this is the tibia, and so this is the meniscotibial ligament. So type 1, this is the tear in the meniscocapsular part, particularly the synovial sheath. The second type is the partial superior. It's the only partial, it's not reaching to the inferior surface, and it's in the meniscus body, peripheral part. Similarly, the partial inferior is type 3. It's not reaching to the superior part. And then type 4 is complete in the peripheral part of the meniscus. And type 5 is the double tear. The same thing you can see here also in this video. This is lesion in the capsular part. The meniscus is clear. And here orthoscopically, if you see, this is the capsular part which is torn, and from here you can see the tibia also. So this is type 1. So next is the type 2. This is the partial superior part in the body of the meniscus, in the most peripheral part. So this is only in the upper part, superior part. Usually it is taken as the stable one. Similarly, the partial inferior, which you can probe from the anterior side. And if it's come anteriorly, then it means it's there. And when you remove the tissue from the posteromedial gutter, then this become complete. So similarly, another type 3 part, you can pull it into the joint, so it's unstable type. And when you place your scope into the posteromedial gutter, and with the help of needle, if you just do the probing, so this the scar tissue will get away, and your the ramp lesion become very clear. Type 4 is the complete meniscal tear, just in the peripheral part. So this is the meniscal tissue, which is tear from the main meniscus in the posteriorly, and type 5 is the double tear, complete tear. So this is the one type 1, and one tear, this is the another tear. So this is the type 5. So with all these classification, the treatment part is that it should be repaired if it is unstable, and repairing should be done from the posteromedial portal, lasso through the cannula, and then put the stitch there. And it's depending upon the size of the tear, it's maybe 1 stitch, 2 stitch, or 3 stitch. So so that it's become a stable one, and from posteriorly it's complete close to the meniscus. So this 17-year male boy presented to us at the 4th week of the injury. The MRI says the complete ACL tear, and also there is problem with the posterior part of the medial meniscus. And with sensitivity and specificity, this separation of the meniscus capsule from the meniscus having the highest sensitivity and specificity. You can see this separation. There is in reporting there may be irregularity or edema, but this separation is the most commonly taken as the ramp lesion MRI wise. So this again scope in the posteromedial portal, needle is there, check for this ramp lesion. So with the knife, portal was made, then the probe was passed, and you can see this much of separation of this the ramp lesion, and going from there to there. So this much of the separation was there. So through the cannula, this lasso was passed. Initially, the standard lasso I use, but nowadays there is ramp lasso is also available. So this is, and this is suture was passed over this lasso part, and the suturing is done, that is the sliding knot through this cannula. And this is there, and you can compass the tissue with the help of knot pusher. And since tear was big, then another the suturing was planned in the similar fashion, and the second stitch was placed, that is the posterior to the capsular part, so that your tissue get as much as closer to the meniscus. So these 2 stitches are there, and this closure of this ramp lesion was done. The second case, this was the chronic ACL getting managed with the rehab. recently having recurrent locking type of sensation. It's not complete lock, but having symptom of locking for last 2 months. So plan for the ACL reconstruction, MRI was clear, only ACL tear was there. But with the history of recurrent locking in the back of mind, this posteromedial corner should be explored. MRI was absolutely fine, there was no problem. And you can see there is rent is there, and this tissue is not very good. So this chronic type of ACL, usually this meniscocapsular part is also get injured with the time. And when you probe it, this lesion will get bigger. So though it's very small, but tissue was not very good and the chances of further injury is high. So repair was planned, and with the single suture, this get closed. So third case, again, the fresh case, injury 6-week-old only. Again, a scope in the posteromedial gutter with the probe in the ramp lesion. This is with the 30-degree scope. So when you use the 70-degree scope, so this much of the viewing area will find. So many recommends that for the ramp lesion, you can use the 70-degree, will give the better visualization. Nowadays, I'm using 70-degree for all my ramp repair. So again, big tear is there. So a similar suturing was, this is the first knot, and then the second knot again outside the capsule. So some recent literature over this. This is in 2018, this American Journal of Sports Medicine, the biomechanical study. What is the effect of this? And the conclusion was the effect of ramp lesion was it increases the anterior tibial translation. So many a time this type of patient will have grade 3 anterior test as well as the grade 3 pivot shift also, in spite of being there is no any other injury, only ramp and ACL will lead to such type of clinical finding. And those who are not repair for the ramp, only isolated ACL reconstruction was done, the pivot shift was still there. And those who are repair, the pivot shift was absent. Though, however, this literature says the effect of this change was minimal, but its statistically significance was found, but the clinical significance remained unclear. It was the biomechanical study. Again, research paper in 2020 about the healing status after this stability. So healing rate of ramp lesion was significantly better in those who are having repair in comparison to those who have not repaired. It means some cases, those who have been not repaired get healed. So such type of finding should be decided orthoscopically, particularly with extension. When your the flap get closed, then such type of the lesion having potential for healing. Even with the extension, this flap don't get closes, then the chances of healing such type with this ramp lesion is less. Anterior laxity in the knee in which ramp lesion was unhealed was significantly greater. So unhealed ramp lesion having higher anterior laxity in comparison to those in which the ramp lesion was healed. And the final conclusion was all inside repair through the posteromedial portal was a reliable surgical procedure, and this helped in the healing of ramp lesion. Thank you.
Excellent talk, Arvind. Nice presentation. Right. So we have any questions? Samsul, anything that has come up on? Yeah, Vivek will.
No, not questions yet. No
okay.
questions yet.
Vivek,
what is your post-op rehab for the ramp repair?
So usually it's I keep
and one minute. At what knee position you tie your knot?
It's the 90-degree always. And I usually keep non-weight bearing for 6 weeks. And range of motion only 90-degree, not more than 90-degree for initial 4 weeks. So this was the thing I was discussing about the circumferential compression stitches. This was the tear having vertical as well as horizontal tear also. So the vertical part was removed, and this the circumferential suture was passed, and this was tied, and the knot usually I try to place posteriorly, but even it's remain anteriorly, this gets synovalized with the time. So another suture, and this is the another. So these three suture give very strong configuration that the novo stitch recently come. Initially, I used to do with the meniscal, this Arthrex company, this meniscal suturing device.
Okay.
Yeah. And nowadays, this Smith Nephew having mini Scorpion also.
First pass mini.
Yeah,
So
first pass mini.
Arvind, you find these lesions, and in your practice, do you think that you might have missed, or most of us who have not been looking specifically for these lesions may have missed, and that would have led to a bad outcome in our ACL reconstruction? Your take on it, and then Bhushan, your take on this, and then followed by Rajeev. Yes.
Yeah, I started doing ramp lesion for last 4 years only. Before that, I was not aware of the lesion, truly speaking.
Right.
So
okay.
In clinical examination, if you find something like bucket handle, patient is having bucket handle tear and sudden it's get locked, then get released. But MRI wise, there is no bucket handle tear. So such type of clinical finding, along with the grade 3 anterior door test positive, is suggestive of ramp lesion. Whenever I find there is excessive excursion of the tibia while their anterior door test, I always look for this posteromedial corner. And the incidence of ramp lesion is increasing every year. Initially, it was 6%. Nowadays, it's almost 25% of the cases, those who are having ACL tear. Okay. So definitely, it's having effect on this ACL reconstruction also with the time, because we have seen literature says the pivoting is still persists, and that is not very good for reconstructed ACL. Thank you.
It can be because of anterolateral ligament as well.
Can I just, okay, sorry, go ahead.
Yeah, Bhushan sir.
Yeah. So I'll just tell you a quick small story. Till 2012, we did not know anything about ramp repair. I visited Sonari Kote Bertrand in Lyon in 2012, and he talked about the hidden lesion of the knee. Till that time, every patient with pivot shift used to get either a lateral tenodesis, either Lemare or a Macintosh in our hands. So this changed suddenly. We found about 20% of patients who actually had a pivot shift test did not have an anterolateral injury, but it was a diagonally opposite area, the posteromedial corner, which had the ramp tear. So ramp tear is also associated with pivot shift test, and we didn't know that till that time. The incidence is around 20%. In our practice now, it's almost 1 in 5, 1 in 4 patients get a ramp repair associated with the meniscal posterior repair. So it's either type 3 or type 4 kind of a ramp tear. So it's very common to do a ramp repair nowadays. And every patient that has a ACL tear, make sure that you go in the hiatus between the PCL and the medial femoral condyle to assess the posterior medial capsular junction, the ramp area, and assess clinically, make sure it's not torn. Every time probe it properly and make sure that you're not missing a ramp lesion, because we are trying our best to reduce the re-rupture rate following ACL, and these are all small missing pieces of puzzle, like the ALL or lateral tenodesis or posteromedial corner injuries. So all of these are small, have contributions to the ACL success. So I think it's important to not miss all of these injuries.
Okay, excellent point. Rajeev, anything you want to add to this?
I think diagnostic round of what we used to do starting from suprapatellar pouch, now you have to go into posteromedial corner also, so that you don't miss the ramp lesion. But in fresh cases, usually you get this ramp lesion. Whenever you are getting in old cases, you will not get it. And I think it's better if you see it, repair it, but don't try to, I don't follow those techniques where people do needling of the posteromedial corner and just create, see whether that tear is there or not. I think those tear usually heals well with rehabilitation. So if you see a tear, its tear is there with ACL tear, go for a ramp repair and ACL reconstruction. The results are quite good.
Okay, so we have two questions coming up online. Romesh, I'd like you to take these questions. So the first one is, hashtag repair supposed to be the strongest repair for radial tear. Have you used these pattern or simple transverse is enough? So in your opinion, what is the best pattern of repair for a radial tear? I think you have mentioned it, but if you can just reiterate the facts again for the listeners.
There was a study which I showed in a slide. It probably in 2012 it was published in a journal, which the hashtag repair is the same which prevents the rip stop. I mean, it's kind of rip stop that we do for rotator cuff. So that they found it is the strongest repair that you can give in radial tears specifically. So it depends on what you are well versed with. So if you have in your armamentarium, if you have those devices which you can use to get the hashtag repair or the Pratt repair, it's called, so you can go with that. Otherwise, if you're comfortable with if it's a small tear and you are comfortable with just a position of the tear margins with a simple horizontal stitches, then also you can probably prevent the consequences. So definitely it is stronger, but if you cannot do it, go with whatever is in your hands, whatever you are comfortable with.
Right. Okay. And another question, I think Rajeev can answer this question. The question is that for concomitant ACL and posterior root medial meniscus tear, is it advisable to use high and lateral portal as described by Freddy Fu, 1 centimeter lateral to patella tendon at the level of inferior pole of patella? So what are your portals, Rajeev, when you have a concomitant ACL and posterior root medial meniscus tear? Do you change your portal slightly, or how do you approach with your portals basically?
Yeah, high portals are always, I think, for routine ACL also, if you are not dealing with root, I make it high portal because it's close to the inferior pole of the patella, because that makes my life easy. Because most of the fat pad I can avoid in making the high lateral portal. It's not like for the root repair or for some special reason I am using it. It's a normal routine portal I use. It's a high lateral portal. Okay. But yes, medially you should have two portal, because in anteromedial and accessory medial, because in one portal you will park your passing loop and another portal you will take your back.
So basically for your medial root tear, you don't do anything out of the ordinary.
Yeah.
Okay.
It's a normal portal.
Yeah, Bhushan, you take on this. Can you just enlighten?
I think that's an unusual combination. Medial meniscus root tear is not that common with ACL injuries. It's the lateral meniscus posterior tear which is more common. But you can have as many portals as you want. Yes. The important thing is not to mess up your surgery and not to be uncomfortable with your suture placement or your portal placement, not to accept a suboptimal result. So no one will question if you have 4 portals on the medial side, but everyone will question you if you get the root repair in the non-anatomical position. So I think it's that's immaterial.
Immaterial. Okay, excellent. I don't think we have any other question coming up on the forum. So if faculty want to put up any question for any of the speakers, let's quickly take 1 or 2 questions before we wrap up our session tonight. We have already 2 hours down the line. Yeah, Romesh, you have
one point to make in bucket handle tear repairs. If you go for the, I mean, I actually saw this in my practice. If you go for a horizontal stitch first, then sometimes as you pull out your first stitch, it comes into the notch. So it's better if you're initially starting, you take a vertical stitch first. That probably fixes the complete meniscus to the posterior part, and then you can go with the horizontal repair. So just a point to make for bucket handle tears.
Sure.
Starting it.
Right. Cinching is more with the vertical mattress than the horizontal mattress, actually. But sometimes if you want cost-effective repair horizontal mattress, you can come out with horizontal mattress.
So
Dr. Bhushan.
One important thing for bucket handle tears is to take sutures on the undersurface of the meniscus. All the all-inside devices are normally designed to take stitches or incorporate the top of the meniscus. Now, if you remember the talk about the anatomy of the meniscus is closely attached to the tibia. So that's why if you use inside out, you can easily go under the meniscus and tether it down to the tibia with the meniscotibial ligament much better. I'm not brave enough to go to the posterior of lateral meniscus, but everywhere else, I would use more often an inside out device. So sutures inside out rather than going for all inside devices as far as possible. Yes, I agree. A vertical suture is much better to tether the meniscus in the posteromedial corner. But try and take vertical sutures on the under surface of the meniscus. Then the meniscus doesn't lift off like that and doesn't salute you every time you go inside. It stays snug to the tibia.
Yeah. So just sharing my experience, what I does in this bucket handle, just I put first the inside out suture. I don't tie that. One of my assistant keep pulling it. So your meniscus reduce it in place. And when you are using all inside suture anchor, this will not get displaced. So this only one suture that is inside out which anatomically reduce it. This will not allow the torn meniscal part to come in the intercondylar part, and also it not allow either it's the tilting of the meniscus when you are putting this all inside suturing device. Thank you.
Question that has come up from a first year postgraduate is that why you have to repair the meniscus while doing ACL reconstruction. Avinash, would you like to take this question? Yeah, unmute yourself, Avinash. Yeah, so just quick answer why the need to repair the meniscus while doing ACL reconstruction.
Apart from all those things like good healing due to BMPs and the stem cells and about osteoarthritis and recurrent meniscus tear, I want to stress on one point that we should not forget that meniscus is a secondary restraint to anterior translation. So when your ACL is torn, it's the meniscus which gives us secondary stabilization to anterior translation. So if we prepare a meniscus with a ACL reconstruction, we are giving a good benefit of a better support of a healing to a new ACL ligament, and in concordance that will help a better healing with a meniscus. So we should always remember that meniscus is a secondary stabilizer to anterior translation and also to the external and internal rotations. So that will be a very helpful if you do a meniscus repair, but that will give a better biomechanics to a good ACL reconstruction.
Okay. Very rightly summed up the gist of why we try and repair meniscus more and more with ACL reconstruction. Okay, if there is anything else that somebody wants to add or add something, otherwise we'll hand it over.
9 o'clock. 9 o'clock we should.
Yeah, Arvind, if you can just quickly wrap up the thing, and before that, I'll thank Bhushan for moderating and all the other speakers and all the panelists who are here with us tonight.
And well done to Sudeep also for moderating the whole thing really well. Yeah. So hats off to you. And the quality of presentation has been really good. Excellent. I was really happy with all the talks, and it was really good to brush up and have a good discussion with all of our old friends like you. Thank you all.
Yeah. So Arvind, you and then Madhusudan, Dr. Madhusudan, to finish up the job of thanking everyone. Arvind, you please first.
Yeah. It was great discussion all about the meniscus, and thank you all the speaker accepting the invitation in very short time and making this webinar very academic one. Thank you.
Madhusudan was, yeah. Oh, you have to unmute yourself, Dr. Madhusudan, yes.
Thanks, Dr. Sudeep. I would like to thank everyone for their time and efforts. It was a very educative and interactive session. Very discussion done all about the meniscus, like the anatomy and meniscectomy versus repair, meniscus repair, these different videos. So I hope it was very beneficial for all the blooming doctors in our association and all over the country. I would like to thank our moderator, panelists, and all the speakers like the Dr. Rajeev Raman, Dr. Bhushan, Dr. Sudeep Kumar, Dr. Neeraj Srivastava, Dr. Arvind Prasad Gupta, Dr. Rakesh Chaudhary, Dr. Prabhat Prakash from Bihar, Dr. Manish, Dr. Romesh Gaur, Dr. Sarthak, Dr. Rajeev Raman, Dr. Vivek, and Dr. Avinash, all the BOA members, all the audience, and Ortho TV, especially the Dr. Shamsul Huda, is the convener of ITO Bihar Arthroscopic Association. And I thanks to all of you. BOA is always with the Bihar Orthopaedics, the Bihar Orthoplasty Society. Thank you. Thank you, everyone. Good night.
Good night, everyone. Stay safe, and thank you once again, Ortho TV, for excellent managing this session. Thank you, everyone. Good night. Stay safe.
Good night.
Thank you.
All.
Stay safe. Stay well.
Good night, Arvind boss. Good night, Sudeep.
Good night.
Good night, everyone. Romesh, everybody.
Thank you.
Thank you, Arvind. Thank
Bye.
you, every speaker. Thank you, Ramesh. Thank
Bye,
you so
Shivam
much.
boss.
Bye, bye.
Bye bye.
Good night, everyone.
Thank you, sir.
Good night, sir. Thank you, Samsul.
Good night,
Very
Sudeep
nice
Babu.
being managed. Thank you, Rakesh sir.
बहुत बहुत धन्यवाद. Thank you, Samsul ji. बहुत बहुत धन्यवाद. Very nice.
Thank you, sir.
सुदीप बाबू को बहुत
Man
बहुत
behind the
धन्यवाद.
scene आप ही हैं, ये जान लीजिए, Samsul बाबू.
हाँ.
Samsul ही man behind the scene है सर. 100% हम मतलब दिल से बोलते हैं कि man behind the scene यही है.
लेकिन आपका भी बहुत बड़ा योगदान है. आपका समसूल का.